So, good morning, everybody. Welcome back to the Journal Club. Today, we'll be discussing the activation trial from JACC inTervention. And our presenter today is Alberto Barioli. And a very warm welcome to our expert, Professor Giuseppe Tarantini. So thank you both of you for joining us, and we can start the discussion.
Okay. So thank you, Arif. Thank you, of course, Professor Tarantini, for being with us today. I'm going to discuss the results of the activation trial on percutaneous coronary intervention prior to TAVI. So it is not working. Sorry for that. Okay. So transcatheter aortic valve implantation is at least equivalent or superior to surgical AVR across high, intermediate, and low risk group. And the presence of coronary artery disease is a predictor of adverse outcome, both in patients undergoing TAVI and surgical AVR. Concomitant revascularization is recommended in patients with significant coronary artery disease undergoing surgery. However, also PCI is usually performed prior to TAVI in patients with severe aortic stenosis and coronary artery disease. But we have no randomized data to support this practice. According to the current guidelines, PCI should be considered in patients undergoing TAVI when significant coronary artery disease is present in proximal segments. And the class of recommendation is 2A with a level of evidence C, so not based on randomized data. Also, we know that physiological evaluation in the setting of severe aortic stenosis is hampered by a reduction in systolic coronary flow and in hyperemic coronary flow, so that FFR might underestimate the significance of a coronary stenosis when a severe aortic stenosis is present. On the other hand, IFR seems a more reliable index. However, the increase in resting flow and microvascular resistance in these patients tend to lower the IFR values. And so that some authors propose the need for lower cutoff values in order to match a positive FFR in these patients. The aim of this trial was to compare pre-procedural PCI versus no PCI in patients scheduled for TAVI with significant coronary artery disease and in the absence of severe angina. It was a prospective multi-center randomized controlled trial with a non-inferiority design, a pre-specified non-inferiority margin of 7.5%, and assuming a reduction of 10% in death in the PCI group, the investigators planned a sample size of 310 patients. So the primary endpoint was a composite endpoint of all-cause mortality and rehospitalization from any cause at 12 months after TAVI. And secondary endpoints were mortality, bleeding events, and MACE, including death, myocardial infarction, stroke, or acute kidney injury at 30 days and 12 months. And these are the inclusion and exclusion criteria of the trial. Patients had to have severe symptomatic aortic stenosis allocated to TAVI by the ART team, and at least one stenosis in a major epicardial artery suitable for PCI. The main exclusion criteria were ACS within 30 days, severe angina, a significant left main stem disease, or contraindication to dual antiplatelet therapies. Patients were enrolled in 17 sites in the UK, France, and Germany. And out of the projected 310 patients, only 235 patients were randomized over a period of 7 years. And this was because of early discontinuation of the trial due to slow recruitment, and maybe because of the tendency for patients to go directly to TAVI after a CT scan assessment and not after routine coronary angiography before TAVI. These are the baseline characteristics of the two populations. As you can see The median age was just over 83 years old in both groups. Patients were predominantly males. In NIA class 3 or 4 in the majority of cases. Syncope was the clinical presentation in about 10% of patients. Importantly, patients were in CCIS class 0 to 2 in almost all cases. The median Euro score was 15, median STS 6.8, and although the baseline characteristics were well balanced between the two groups, you can see that there were higher rates of higher incidence of prior myocardial infarction and peripheral vascular disease in the no PCI cohort. These are the angiographic details of the two populations, and you can see that most of patients had one vessel disease and one vessel intervention, 71% of patients, and the remaining were two vessels angioplasties. The disease was located mainly in the left anterior descending artery and in general in native coronary arteries. These are the procedural characteristics of the patients. PCI was performed in 97.5% of patients in the PCI cohort. The median lesion length was 17, and the median number of treated lesion 1, as well as the median number of stents implanted. Interestingly, 17% of patients underwent bare metal stent implantation. TAVI was performed in 92% of patients in both groups, and almost the majority of these TAVI were with transfemoral access and with an implantation of a balloon expandable valve. And these are the main outcomes of the trial, so death and rehospitalization at 1 year. You can see that the rates of this endpoint are quite similar in the two cohorts, 41.5% in the PCI cohort versus 44% in the no PCI cohort. The risk difference was minus 2.5% with an upper confidence interval of 8.5%. So in this trial, the criteria for non-inferiority was not met, and the p-value was 0.067. And these are the Kaplan-Meier curves for the main endpoint. You can see in the darker black the PCI group, and in the lighter black the no PCI group. The curves, as you can see, are quite superimposable. And these are the individual components for the primary endpoint. So the higher rates of the primary endpoints were mainly driven by high rates of rehospitalization in both cohorts, 34.5% in the PCI group and 33.6% in the no PCI group. And no differences were observed between the two cohorts in terms of both mortality and rehospitalization. And these are the bleeding events. As you can see, patients in the PCI cohort had more frequently bleedings, 44.5% versus 28.4% in the no PCI cohort, with a 40% reduction in bleedings in the no PCI cohort and a significant p-value. And almost all these bleedings were 0 to 3A according to the Barker classification. And as you can see, at 1 year, there were no differences in major bleeds between PCI and no PCI patients. Then if we look closely for the timing for this bleeding to occur, we can see that from the data of TAVI, almost all bleeds occurred in the first month after intervention. Maybe the higher rates in bleedings are due to the different, in the PCI cohort, are due to the different antithrombotic therapy in the two cohorts. You can see that patients randomized to PCI were more frequently on warfarin at randomization than patients not undergoing PCI, but this difference was no longer detectable at discharge after TAVI. However, patients in the PCI cohort were more frequently on dual antiplatelet therapy at discharge after TAVI and at 30 days follow-up, with the rates almost doubled when compared to rates in the PCI, in the no PCI cohort. So maybe the difference in bleeding are due to this different antithrombotic regimen in the PCI cohort. These are the secondary endpoints of the trial, so MACE death and MACE stroke. You can see that both at 30 days and at 12 months, there are no differences between the two groups. This trial had several limitations: the lower than planned sample size, first of all, the absence of a screening log and of blinding, and the results in this trial reflect the outcomes in an old population with an average age of 84 years old. So this was mainly related to the fact that in the first year of the last decade, patients were randomized to TAVI, were undergoing TAVI if they had a high risk or if they were inoperable. So patients were older. Also patients with left main stem disease or those with significant angina were excluded from the study, and the assessment of coronary disease was not based on physiological assessment. So in conclusion, activation is the first randomized trial of PCI versus no PCI in patients with severe aortic disease and concomitant coronary artery disease undergoing TAVI. And the authors found no difference in the primary endpoint of death or rehospitalization at 1 year, but the trial failed to reach a non-inferiority margin of 7.5%. There were higher bleeding rates in the PCI group, mainly due to the different antithrombotic regimen in the two cohorts. And analysis of key secondary endpoints demonstrated no differences in MACE at 30 days and 1 year. So thank you for your attention, and these are some points for the discussion.
Okay, great. Thanks, Alberto, for the summary of that paper. Professor Tarantini, can I invite you in now to comment on some of these considerations that Alberto has raised? So first of all would be that should we consider changing our clinical practice based on the results of this trial?
Actually, first of all, thank you for having me on. Actually, it's even though it is 7 a.m. in the morning, it's a pleasure, because if I look at the people that are connected, you can see that the lights are dim. It means that probably many people are still having a coffee, but actually, I see a lot of people. This means that a lot of people want to be involved in this kind of project. So I think congratulations to all the organizers of Journal Club. Having said that, I would like to say, one thing. The guideline recommendation, as Alberto showed before, is clearly show that you have to do a PCI when you have a severe lesion in a proximal LAD or proximal coronary artery tree, but actually the level of recommendation is C. That means that it's just an agreement among the task force. We don't have evidence. This is the evidence that's, at least to me, shows clearly that you need to avoid over-treatment or, under-treatment of this patient, because when you have a patient with ACS, you have to treat this patient. But actually, when you have a stable coronary artery disease, you have to think twice, because for a patient that is older than 80 years old, being safer is much more important than be effective. So this is a total different world and total different animal compared to younger patients. So in perspective, we have to see what is going to happen for younger patients enrolled, for instance, in other patient, low risk in younger patients. But so far for the common treated patients that are older than 75 years old, we have to consider the possibility that this patient bleeds, much more than the patient that won't go for PCI. So there are two levels of discussion. The first one is the indication. As you told before, the indication need to be really accurately selected. That mainly is based on ACS, acute coronary syndrome or very symptomatic patients. So in the case of a lesion that you spot during an angiography as a play or chance without any angina, etc., probably is recommended to evaluate, unless you have a lesion on the left main, if this lesion is significant in terms of reduction of coronary flow reserve, because you have to consider that when you go with double antiplatelet therapy, this patient bleeds more in the first months after they start this antiplatelet therapy. So actually, when it's extremely neat, probably it's important also to go for a stent that is supposed to to have a depth that is as less as possible. That means less than 1 month. And we have some stents that permit that, especially in older patients. The second point is, what about the pharmacoinvasive strategy? Because Alberto showed that in this patient, probably there is a kind of adverse interplay of the NOAC or anticoagulants together with the DAPT. Actually, we know by the Envisage trial that is published on New England, that's when you go in TAVI patient with NOAC plus antiplatelet therapy, this patient bleeds more. And actually, again, this is my takeaways. Less is more always in this kind of patient, TAV treated patient and older patient, because piggybacking what we have learned from the Envisage, we know that we have to reduce the dosage of the NOAC, for instance, when we compare to the VKA, and actually it's better, if possible, to avoid to make an unneeded PCI, or when you go for a needed PCI, you need to try to be, to keep the triple therapy, not for a long time, ideally for a few days, and then to go for dual antiplatelet therapy and to use a stent that permits also to have a dual antiplatelet therapy that is less than 1 month.
Okay, great. So on the topic of the different populations between acute coronary and stable coronary disease, there's a question in the chat about, should these authors have thought of a different study primary endpoint, perhaps rather than looking at mortality and rehospitalization, looking more at quality of life and angina, considering it's a stable population? Would that have given us something more useful?
But actually, I think when you have an acute coronary syndrome, the reason why the patient has been admitted in the hospital is the acute coronary syndrome. It's not the aortic stenosis. So you need to, prioritize your intervention. Actually, when you have an occlusion, a primary acute coronary syndrome, and not, what we call 2B angina Brownwell classification, just to recall, this definition. In that case, when you have anemia, etc., this is a total different animal. But actually, when you have a primary acute coronary syndrome, that means an acute thrombosis of the major proximal coronary arteries, I think you have to fix this kind of lesion, because this is the main reason of death in the patient. And then you can postpone. I think it's not needed, to go simultaneously for TAV in this patient, because actually the pathophysiological mechanism of this disease is totally different. When you have a stable disease, actually nobody dies because of stable disease in few months. So the mortality by Courage and all the other trials is about 1%. So we have to keep in mind that this is not an emergent intervention that we have to do. And only in case you have a severe angina, okay, or a worsening of angina, or a huge, ischemia in the ventricle, that means really a left main or last main vessel, etc. I prefer to postpone the coronary intervention, favoring, the treatment of TAV in this patient.
Okay, thank you. There's a couple of questions about the lesions, the type of lesions, and whether we've got, if we had more diffuse multi-vessel complex disease, or the PCI was likely to be higher risk PCI, calcifications, maybe needing rota, for example. Does that change the threshold for intervention before TAVI?
And actually, obviously, this is a kind of things that is, self-explanatory. If you have, on top of what we have discussed, that probably is not needed to treat all these patients, even those patients with proximal lesion at the level of the coronary, if the patient has not a proof of ischemia or angina, it's even more, clear the concept that when you have to face complexity in the absence of a real clinical need to perform this PCI, it's better to avoid, especially in 80, 82, 85 years old patients. So the point is, I think that the final message is very clear. All these patients die or have a major problem, rehospitalization, because of bleeding. Nobody knows if they don't have any hint, any clues, any suggestion that there is any kind of benefit in terms of efficacy. So this is, I think that's, in Latin, the people say primum non nuocere. That means the first things that you have to think is to not harm the patient and not to get him living forever. This is the point.
And Professor, sorry, what do you think about younger patients? For younger patients, do you think that the indication for PCI is a little bit different?
Well, actually, again, I think that we need to be really stick to the evidence. We know that stable coronary artery disease is not a deadly disease, because actually you have time. This is the point that we know from the past literature. So also in a 72 years old, we don't have to think similarly to the surgeon that open, the chest, and one time they have to replace the valve and then to do simultaneously the PCI. Actually, we have time. We can, we have to think the whole path and the sequence. So if the main reason of the hospitalization is the acute coronary syndrome, we have to fix the acute coronary syndrome and then to postpone leaving out, getting rid the patient of another antiplatelet agent that is not needed when you go for TAVR, because that by popular TAVI that SAPT it's better than DAPT. So in that case, it's better to fix the coronary and then to stage the TAVI. The way around, you have to fix the TAVI if the patient if the patient is asymptomatic and you don't have any evidence of severe ischemia, you have to fix the TAVI, and then you can think twice and you can stage the coronary. On the contrary, when you have a very severe proximal left main plus TAVI, you need to judge, and I think there is still room to think about which comes first. And sometimes in our practice, we prefer to fix the left main first or the proximal LAD with ischemia, and then we postpone and we stage the TAVI.
Okay. If anybody has any other questions, I would encourage them to come onto the screen and certainly ask them. In the meantime, Prof, if we now fast forward the discussion, let's say you've decided to defer the PCI, you've decided to perform the TAVI, and then the patient comes back with an indication to perform PCI. So now we're into the realm of post-TAVI coronary access. So it's obviously there's a lot of discussions, and a few days ago was a PCR course as well. And so I would like to know, for us fellows, from your point of view, how much of a problem really do you feel is post-TAVI coronary access? And in your experience, for those of us who are, early in the cath lab, what can we do when we're faced with this sort of scenario?
I think this is a very, very, very important question. I will tell you, my truth. Because as you know, there are a lot of evidence, a lot of people, different schools of thoughts. Actually, I'll tell you my thoughts. So the point is, first of all, the most important thing is when you have, the clues that you have to treat this patient in the near future, the first and most important thing is to select the most appropriate prosthesis. Actually, this is important because there are many different, we have published many papers in this regard. There are other papers from Lars, from Azim. We published also 4 to 5 papers in this regard, but actually the point is that a short valve is not the same to the self-expandable valve because you stay below the coronary the coronary takeoff and the coronary plane, so you have a free access to the coronary when you go for a short valve, balloon expandable valve. Actually, you may orient the valve, the self-expandable valve, but again, we published in another paper that you may reduce the gap, the difference, but actually the difference is still there, and this is statistically different. So actually having a frame, even though oriented, close by to the coronary artery is something that may hamper or get more difficult the selective engaging of coronary artery. But, when you have to face a patient that is already a valve there, if the valve is not oriented, it's a big mess, because if as a play of chance you have the skirt, the asymmetric skirt that is the triangle that is in front of the left main, is very difficult, because you need to go from the nearby, you need to use many tricks, like guideliner, extra support catheter. You need to use different type of wire, and you are not aligned and orthogonal with the catheter, so it might be very difficult. So first of all, the takeaways is that when you go for the first attempt, you always have to orient the valve to be sure that you get the coronary ostia free for the access with the catheter. Secondly, and this might be ideally very important to have, in the patient report, to be stated in the final report of the TAVI, to say, okay, the valve is oriented, and this is important if the patient will be admitted in another hospital. Actually, when the valve is not oriented, it might be very tricky, but actually there are many different ways to engage. First of all, I would like to suggest to not select catheter like XB, EBU, etc., because the way to incannulate, to engage the coronary artery, is not bottom up, but is top down. So you don't have to tilt up, because it's not possible. You can damage the leaflets of the TAVR. So you have to select the appropriate catheter to go down. Many times, we use the Judkins, the simple Judkins for that. And then you need to be ready to use sometimes microcatheter or extra backup catheter, etc., and different type of wire.
Okay, thank you for sharing some of those techniques. Any other questions on the chat by anybody? Or any other comments about this trial? I think we have a real expert when it comes to this topic, so now's a good opportunity. Or any issues you faced in cath lab, for example, from any of the fellows, would be a good chance to get some questions. I have a question we faced a few months ago, actually, was the concept, we're trying to do a PCI, had an EBU, and then suddenly the pressure crashed of the patient due to probably leaflet pinning, because I think the EBU just pressed down on one of the TAVR leaflets. This was a core valve prosthesis. Do you routinely, as you said, you have to come from a top-down approach and not go from bottom up? Would you ever change your guiding catheter based on this risk, or how often have you faced this risk? In our case, it was very dramatic, sudden hypotension and severe regurgitation.
Yeah, yes, this is important also, your comment, because actually you have to think that the leaflets are sewed. So the point is that you can tear it up, and this might be a problem. So my suggestion is to start with the Judkins, with normal Judkins that are very gentle in the landing at the level of the ostia. So avoid to push too much, to force, to tilt up the catheter, because as you told before, you may have a really bad surprise that may really harm the life of the patient. So this is my suggestion. Actually, is also a suggestion included in many review we did as other PCR course, live in a box, etc. explain all this point. The way you have to engage the coronary when you have the prosthesis there is to land gently, but top down. You don't have to tilt. This is a very, very, very important point, especially when you have a valve that is very narrow, etc. Because actually we're not dealing with aortic insufficiency with a prosthesis of 34 or 37. We are dealing about prosthesis that are sometimes small. and actually to tilt up, if you look at the curvature of the EBU or the XB, actually, the angle, the curvature is huge. So you cannot think to tilt up in a valve that is, 23 or even less. That is the point.
Okay, so thank you very much. I think that almost takes us exactly onto time. So it just leaves me to say a big thank you, Alberto, for presenting the paper and discussing the article, and Professor Tarantini, a big thank you again for joining all of us so early in the morning. As you said, I think you really, enriched the discussion for all of us, and we appreciate a lot of your comments and experiences that you shared with us. So big thank you for joining us. Thank you, everybody, for joining the Journal Club, and look forward again to seeing you next week.